Well, I can start without the slide. So my task today is to introduce you to the fracture reusable service model here. And my disclosure is I only have one. I volunteer for Osteoporosis Canada. You'll hear me use the acronym OC, that's for Osteoporosis Canada. I use it so often that I'll forget myself and use it. Okay, great. So what I'm going to go over is the fact that we have a problem, which are fragility fractures. And there's a huge post-fracture care gap. There is one and only one solution that can meaningfully close that care gap, and that is fracture liaison service, or FLS for short. I'll also go over the common traps that we've seen across the country and indeed internationally as passionate teams have tried to implement models of care to close this care gap. And throughout this, I'll speak to some of the support tools that Osteoporosis Canada has put together. And I'll leave time at the end for questions. So, fractures are not benign events. For example, the broken hip is one of the most devastating osteoporotic fractures. After a hip fracture, less than half of the patients will recover the full level of independence that they had prior to that broken hip. And broken hips are usually expensive to the healthcare system. In Canada, the average cost is a bit greater than $60,000 for the first year following that broken hip. But we also know that after one fracture, the risk of a second one is high. And that risk is also imminent. And I'm not proposing to go over all of these statistics, but I think they illustrate exactly how high and imminent the risk is. After a broken hip, there's only one more hip left to break. And yet close to 10% will break that other hip within 1 year. 15% will do so within 2 years, and 20% will do within 5 years. And if they don't come back with a broken hip, they're coming back with some other fracture. So the patients are stuck, very much like Larry has been, in this vicious cycle of recurrent fractures. And this need not be so at all. We actually have effective medications that actually have been proven to reduce the risk of fracture. They're not perfect, but they work relatively well and relatively quickly. And they reduce the fracture risk by about 50% within the first year of initiating that treatment. Those medications are quite inexpensive. In fact, the most common drugs that we use cost less than $400 a year. So what do our guidelines say? They actually say that fragility fracture after the age of 50, we should do an investigation for osteoporosis and or initiate osteoporosis treatment. This is not controversial. This is part and parcel of all national and international osteoporosis guidelines. It's also not a new message. At Osteoporosis Canada, this has been part of our guidelines going back to 1996. That is a quarter of a century. So if we're doing right by fracture patients, we should make sure that they're actually getting BMD testing, that they're getting the treatment that they need. And because our treatments are effective, they will reduce the risk of fracture, reduce human suffering, reduce mortality, and reduce healthcare costs. And I do want to point out that you do need to reach a critical level before you can actually reduce subsequent fractures. The model of care needs to increase the number of patients who receive appropriate osteoporosis treatment. Otherwise, the model will fail. So a model that increases bone densities but does nothing else will not prevent fracture. So I'm going to focus all the time on this clinical care. And I'll start right here. So this is from the Public Health Agency of Canada, and I'll walk you through this slide. So in red are women, in blue are men, and we're looking at data from 2000 to 2015. This is the proportion of patients who had a major osteoporotic fracture who were initiated on osteoporosis treatment within 1 year of their broken bone. And as you can see that at the peak in 2009, only 26% of women and 17% of men were offered that treatment. The care gap is huge. And this is an international phenomenon. It's not just Canada, it's been recorded everywhere where it's been measured. And what's more concerning is since 2009, the situation has worsened. And this is also an international phenomenon. We are not winning this battle, we're actually losing. The care gap is so huge that worldwide there have been caring healthcare providers, administrators, and researchers who have tried to close this care gap. And if you look at this, we've been doing this work for the past 25 years. And there's been no improvement. So this can give you some insight right at the beginning of this presentation, is that if there was an easy solution for this, we would have already fixed this problem. So there have been so many interventions done for this that we've classified them and subclassified them at this point. So let me go over first the non-targeted interventions. When you're trying to improve the care the patients get without connecting directly with the patients themselves. So for example, if you hired me to give education to all of the family physicians in Surrey to improve the care that the fracture patients receive, this would be indirect, okay, and non-targeted model. So it's a quick thing about that one, because all non-targeted interventions, without exception, have resulted in zero improvement in the post-fracture care. That is very consistent. I'll give you an example. So in 2010, Osteoporosis Canada published evidence-based clinical practice guidelines. The big focus of those guidelines was specifically the post-fracture care gap. When they were released in the CMEG journal that went to most of the physicians in the country. The medical schools across Canada did CMEs, lots of education, and yet you see any significant impact to the care gap? None. Okay, so this is consistent. So what about the targeted intervention? That's when you're connecting directly with the patients themselves. And that is the premise of targeted intervention. You must capture or connect with all of the fracture patients. And that can only be done if you do systematic and proactive case work. So there's been so many of those that we've subclassified them. So we consider that 3 I's for identification, investigation, and initiation of treatment. So if the model captures the patient, it may provide education to the patient, but that's as far as it goes. It's considered a 0 I model. If the model captures the patients, and on top of that sends an alert letter to the family physician, it's a 1 I. If the model also does the investigations needed, it's a 2 I. And if the model does all of it, including giving the prescription to the patient, it's considered a 3 I. And in 2013, there was a landmark study that was published, a systematic review and meta-analysis of the many interventions that were published. And this is, again, my focus is on initiation of treatment. here are the results. And as you can see, there's a considerable margin of difference once a model hits 2I or 3I. In fact, the other thing that you might notice is to be a 2I and 3I model, what is consistent of these models is they're all coordinator-based. Osteoporosis Canada is a very evidence-based organization. And we look to this data to define our own definition of FLS. And you will see that it needs a dedicated coordinator, and there needs to be attention to all 3 I's, specifically systematic and proactive case finding. There needs to be appropriate attention to the investigations needed, and the model needs to facilitate initiation of treatment. If it's 2I, it needs to make a strong recommendation to the primary care provider. And if it's 3I, it has to give the prescription to the patient. We've further elaborated on that definition, defining the 8 essential elements of FLS. Those are the bare minimum characteristics of models to be successful. And some of those essential elements are so important that we demand of the FLSs that they measure key performance indicators for them. So, was that Ganda meta-analysis the only publication on this? There's been numerous publications on FLS since 2013. I'm just offering you one systematic review and meta-analysis. This one looked at improved clinical care. And you can see that there's a doubling of the treatment rate with FLS. So there's always a meaningful impact on the care the patient receives. But, you know, we really do this to improve the clinical outcomes the patient gets. And in fact, we do also see that. You can see that FLS reduces the subsequent fractures and reduces mortality. So this is not controversial information. FLS works, okay? And so this is important. So despite the fact that we've known that FLS works for a decade now, it's still a very rare animal in Canada. Less than 15% of Canadians with fracture currently have access to an FLS. I'm listing here where they are located. You have 3 in BC. And we recognize 3 different types of FLS. The combined inpatient, outpatient FLS. But we also recognize those FLSs that work only in the inpatient setting or only in the outpatient setting. But I can tell you that of the 49 FLSs on the OC FLS registry, 100% of them have a dedicated FLS coordinator. 100% of them do systematic and proactive case finding in the orthopedic settings. And all of them reach at least 2I, 3I in accordance to the evidence. So remember I said this care gap had compelled a bunch of caring providers and administrators and researchers to do models of care to improve this. I am not a researcher. I'm just a regular clinician. And yet I was compelled to do this. And I started doing models of care in Nova Scotia dating back to 1998. I did a total of 19 interventions. Over the course of about 15 years, and they were intensive interventions. 9 of them were province-wide with support of my provincial government. 9 employed dedicated staff. 11 of them involved other people. So it might need participation, active role for the orthopedic surgeon and the osteoporosis specialist and the EMD radiologist and or the family physician. So you can see that I've brought in lots of my colleagues into this work. And so we needed to look at the care gap. And we're very challenged in Nova Scotia because we don't have good access to good data. But in 2010, we finally got our results. And I was sure we were better than the average in Canada after doing all of this work. And this is for hip only. Only 20%, 23% of the hips were offered osteoporosis treatment after the broken hip. So I can tell you that this was eye-opening for me. I'm looking at this after 15 years of my trying to fix it. I know that I'm standing in the exact same spot that I was standing 15 years ago. I made no difference whatsoever. Now, I got to say, at the time, all of these interventions were very smart, well thought of interventions. But now I can look at it from the get-up lens. And why did we fail? Well, none of them was an FLS. Okay, 10 were non-targeted interventions, 6 had complete failure of the first eye, 1 was a 0 eye, and 2 were 1 eye. So no wonder. And in fact, I went back and reviewed not only my own intervention, but I took that Ganda lens and reviewed all of the interventions that I looked at over the preceding 15 years. The FLS community, or the community that's trying to close the care gap, we're a very tight-knit group, and we connect with each other. And by the way, you know when an intervention fails, it's not likely that they're going to publish it. So the fact is, I looked at everything that I see, including my own unpublished interventions, my colleagues' unpublished interventions, and this is both across Canada and international, as well as the published interventions. And when I look at everything together, this is my conclusion. Only 2% of what I saw actually worked, and that was FLS. And 98% of what I saw did not work. In fact, it failed miserably. And you may think that the most important part of this is the 2%. But to really be an expert in FLS, you need to be able to recognize those models that have failed. And I think that's the important part, and that's what I want to spend in the next bit. We have identified the 10,000 ways that will not work to close this care gap. And I want you to avoid spending 15 years roping in all of your colleagues to do models of care that are really doomed to failure. Okay? So there are common traps. So I think I'm pretty smart, but I know others are smarter than me. And I've seen what smart teams have done across the country. So I want to go over some of the traps. So obviously you need the first eye, you need the second eye, and the third eye. So what happens if you just do the first eye? And actually here we have published data. So this is a model that doesn't quite reach a 2-eye, 3-eye. So there's usually a robust, systematic, and proactive case finding, and there's an alert letter that goes to the family physician. Dear Dr. Smith, the patient, Mrs. White, broke her wrist. This is likely a result of osteoporosis. Please do the investigation needed, and please, if warranted, start them on treatment. I mean, doesn't it seem like a no-brainer that this should work? So this is really good study. I think this is a brilliant study, actually, by Bill Leslie in Manitoba. A large randomized controlled trial of men and women who suffered fractures. And 3 interventions, 3 arms, the usual care arm or the control group, The first intervention arm, the alert letter goes to the family doctor. And in the second intervention arm, both the family doctor and the patient themselves receive the letter. Patient's letter says, please book an appointment to see a family doctor because that broken wrist needs to be investigated for possible osteoporosis. So the control group, you can all predict what it's going to show. Don't live with that. Okay, pretty poor. Okay, and that's what we expect. We know we have a huge gap. Just think of what you think you expect for the two intervention arms. Okay, these are the results. Yeah. You need to give kudos where kudos are due. This is a statistically significant improvement in the care that these patients receive. So, and there's no statistical difference between the two interventions. So there was no added benefit to sending the alert letter to the patient. I think you can all recognize that the post-fracture care gap is still alive and well here. The overwhelming majority of patients are still left alone. So now I'm going to leave in that font the Manitoba. I'm going to put in red font a one-eye model that was done in Alberta. So only two arms here. Again, it's a large study. But this one, they went a little bit more intensive. They hired a dedicated coordinator who phoned the patient. So no alert letter goes to the patient. They get a phone call. They get some education on their fragility fracture, and they get prompted to go and arrange an appointment with their family physician. So I'm going to show their results in red. Okay. Amazingly similar results. And it boils down to this. No matter what bells and whistles you add to a one-eye model, if it's a one-eye model, it's still just going to get one-eye result. This is very, very consistent. Okay, so what about if we look at it the other end of the spectrum? So you've got the second and third eye, but you don't really address the first eye. And I've seen this implemented across the country as well. So what you have is, as a rule, the osteoporosis specialists, we all want to be closing this gap. And what we have access to is our own clinic. So this model can be done with or without additional dedicated staff. And you know, in the osteoporosis clinic, you've always done an expert second eye and third eye. So now you're missing the first eye. What you usually do is you ask your colleagues, the orthopedic surgeons, the emergency room physicians, the primary care providers, to refer their fracture patients in. Okay? Now, I do not have published data. I can only tell you what has been reported to me, but the pattern is always the same. We've seen this happen in almost every province in the country. Going to fail. So let me do first an reality alert letter in Manitoba. Remember, I gave you this data, but it only resulted in 80% of patients getting intervention. I've not seen that type of model say to in the alert letter, please refer the patient to an osteoporosis specialist. But I can kind of guess what the results would be. The same. But here's the thing. This model that we just seen in the osteoporosis clinic, there's not even that alert letter. So my expectation right off the bat, based on evidence that we have, is that likely the referrals are not going to be huge numbers. And in fact, the pattern always seen, and I've got FLS in brackets here because it does not meet our definition of FLS and osteoporosis Canada, is that usually when you implement this, you prove the model to your colleagues. There's an initial surge that comes in of referral. The surge itself is a lot smaller than what you anticipated to start with, and it filters out fairly quickly. So what you end up with is there's a little trickling of referrals more than we had before, but the overwhelming majority of the fracture patients are still left behind. But I want to give some of the benefit of those models. So for the patients who do get referred, they are getting a valuable service. Okay, so we need to recognize that, but it's not an FLS. It will not have a meaningful impact on the post-fracture care gap. Okay, so what if you had the first eye, the second eye, the third eye, and you said, well, we're not going to do a dedicated FLS coordinator. And I've seen that done. In fact, I've done that. Okay. So in this model, you've got a super keen team, and this team has knocked upon healthcare administrators' door after administrators' door after administrators' door, and they've got no funding. So after 2 or 3 years, you say enough is enough. We need to do something. And so what you're reduced to doing is assigning the 3 eyes to different bodies. So you're dividing up the FLS load. So you typically assign the first eye to the orthopedic surgeons or the nurses, the ER physicians or nurses, or the radiologists. And you assign the second eye, third eye to either family physicians or osteoporosis specialists. And I actually have one study to show you on this that's been published. It's going to be okay. So before I show you the study, I want to give you reality. In a true FLS, a full-time FLS coordinator can manage about 300 to 450 fracture patients a year. It's a full-time job. Where else in healthcare can you stop a full-time job and still do it? Okay, so this is the Jean Talon. They had a dedicated FLS coordinator funded with research funds. And when those funds were exhausted, they decided to incorporate the FLS function within the existing healthcare system. So they've assigned the educated, the ER nurses, and the orthopedic nurses to identify fragility fracture patients. And the only thing they're asking them to do is refer them to the medical day. Okay, and the medical day clinic to look after. This was done only for non-hip fractures because they still had a dedicated coordinator on the ward. So out of 190 patients, only 54 landed in the medical day unit. I'm quoting directly from the study. This is not the proportion of patients who were initiated on treatment. Okay, so you see that you're getting back to almost PIAC levels. Okay, so quite honestly, this is the majority of patients are still left behind. So here's the other thing that I'm going to do. I've seen teams that they tried to divide it up in the function of just 3 people, and it fails. So then you say, well, that's because we gave too much of a job to the people. So let's divide it up in more people. So that everybody gets a little tiny bit. And here's the thing, and this is invariable, okay? The more people you spread the work out to, the less effective the model becomes. Okay, and I think that's because nobody's really responsible. They all think the other guy's going to do it. Okay, nobody's accountable. Okay. So I do want to say one more thing. So you design your model, and it looks like it meets the Gandhi definition. And you decide that that's good enough. You don't need to measure anything because that's going to work, guaranteed. Well, I think you need to measure KPIs, and so here we go. So you assume all the great results are happening. And you know, if Bill Leslie had assumed he had great results, he would have been in for a shocker. Okay. But here you go. So I'm going to give you the results from the second national FLS audit that Osteoporosis Canada conducted. And here we're going to focus on the range of the audit. So you can see that this is true FLSs doing their best. And you can see that even with that, you can see that the range, you see how hard it is to get to these numbers? Okay, the proportion of patients who reach, so this is KPI 1, that's hips and non-hips non-spine for the identification. This is KPI 2 for the investigation, and this is KPI 3 for initiation of treatment. So it's hard work, and if you don't measure your results, you do not know exactly how many patients you are leaving behind. I'll give you another example about the importance of the KPI and the right KPI. So here's 2 examples. So in both cases, there's 600 fracture patients a year. And in this one, they lose a few in the first eye, they lose a few in the second eye, they lose a few in the third eye. And by the way, that's exactly how it happens in an FI. In this other one, you see they lose quite a few in the first eye, but they're amazingly great for the second and third eye. And that would be a little bit more typical of what you would see in an osteoporosis clinic. But see, this is what they're reporting. This one is reporting the 300 over 600, and you can say they're 50% effective at getting the proper care. And this one is reporting 95 over 100. You see how that changes everything? The most effective model now looks like it's ineffective compared to the least effective. So it's important that we have consistent KPIs with well-defined numerators and denominators. And Osteoporosis Canada has done that. So we look at the fracture patients that are seen in the hospital, what proportion were captured by the FLS. Now, those patients were captured by the FLS. How many underwent the appropriate investigations to determine their fractures? Of those who were at high risk, what proportion were initiated on treatment? And of those who were started on treatment, what proportion are persistent at 52 weeks post-fracture? So to me, if you look at just this, this will tell you some of the traps that you don't want to fall into. So me, this is my big expertise, models that don't work. If I change my tune, of course I have. So I smartened up in 2009, and it took me until 2013 to find funding for true FLS. We implemented that at Dartmouth, and we used the data from that FLS to then convince government to expand to Kentville and to Cape Breton. So I'm going to give you some of our results. Oh, and by the way, we're not finished because there's 2 hospitals, the big monster hospital, QE2, that has the biggest fracture volume of them all, and one in Glasgow that do not have access to FLS. So I smartened up by now. I did not go and reinvent the wheel. I went and looked at the models that had successfully implemented and proven their work. And I went to them and just replicated their model. And Dr. Bogash might not even remember this. He's counseled so many people, but he gave me a lot of good advice that I followed. And that's helped us be successful. And Dr. Bogash, the Brookfield chair, will be speaking later this morning. Our FLS in Nova Scotia falls under primary health care. That's where the funding is. That's who the nurses report to. But they don't work in primary health. They actually work in the orthopedic service. In Nova Scotia, you have to adapt your model to your local context. In Nova Scotia, we can get an expanded scope of practice for our RN, the care directive. And our care directive allows our FLS nurses to order BMPs, spine x-rays, and blood work as warranted. And our FLS is point of care. They see the fracture patients in the ortho service when they're accessing. So on the ward or in the CAS clinic. And anything else is done by phone follow-up. So our FLSs were doing virtual care well before the pandemic. This is just a very oversimplified view of our algorithms, and we measure our KPIs, and this is all done very independently by our amazing 3 FLS nurses. So I'm going to give you our results from that second national FLS audit. I will give you some insight into the background. So we're using the street light system. So green means that the model is at or near optimal. In yellow, it's a reasonably good model, but there's still lots of room for improvement. And if there was a red background, it would be a priority for improvement. So these are our results. And as you can see, we still have lots of room for improvement. You can probably also see that this FLS did a lot better than the other 2. And this is not because the FLS nurse at Dartmouth General is way better than the other 2. It's got to do with resourcing of the FLS. Dartmouth General Hospital has the smallest fracture volumes of all of these 3. And they hired one full-time FLS coordinator, plus they assigned that coordinator some admin support. So all of our time is spent on clinical care. The other 2 hospitals have a larger volume of fracture, and yet the hospitals only hired 0.8 FTE, and they also did not give them any admin support. So these super well specialized FLS RNs have to spend some of their valuable time booking bone density and phoning patients to their appointments. Okay, not very good, but it explains this. And by the way, when we get those results, we use them to advocate for improved allocation of resources. So it's very important. So just so you know. Okay, so, but I really wanted to close the care gap. To me, that's not sufficient. Okay, I've been talking to you about FLS improves the care gap. So what does it do? So this was the one data that we have, and even in 2022, we can only access data for hip fracture. But I want to point out, so this was in 2010, and this 23% of hip fractures, that was all hip fractures, whether or not they're on osteoporosis treatment at the time of their broken hip or not. As it turns out, 13% were already on treatment and continued on treatment post-hip, so only 10% were newly initiated. So I'm going to want to compare to PX. So I'm going to give myself the hardest denominator I could. I'm going to use all of Nova Scotia's hip fracture patients, even though only 50% of the hip fracture patients in Nova Scotia currently have access to an FLS. Okay, so you can see that's pretty close to exactly 50%. The 3 FLS hospitals and the 2 hospitals without FLS. So this is the PIAC data. So 65 and up, both sexes. Because PIAC excluded patients who were already on treatment at the time of their fracture, that's what I asked for my department of health. I did ask for a different timeline. So PIAC was looking at initiation within 12 months of the fracture. I asked for only 6 months to be in line with the KPIs that Osteoporosis Canada has. Do I think that that disadvantages us at all? Not a bit. I can tell you in our FLS, if we haven't managed to initiate the patient on treatment by 6 months post-fracture, it's a lost cause. It ain't going to happen. The only place where we're really differing is PIAC has access to all 5 of the fractures that we document, which is hip, wrist, humerus, pelvis, and spine. And in Nova Scotia, we're challenged, we can only access the fracture data. So here's the results. So in green, this is the PIAC data for men and women combined. And this is 3 data points, pre-FLS. I know this is not very glorious, but I know we're not out of bounds to other provinces with no FLS. So we implemented our FLSs here. The last two were implemented back to back. And remember, my denominator includes all of the hip fractures in Nova Scotia, even though they don't have access to FLS. But you know, this is 50%. Surely I've made a dent. This is the dent we made. Okay, so we're not at the end of the road here. We have a long way to go still, but there's no doubt in my mind that FLS is making a meaningful dent in the fracture patients. Even with that hard denominator, I've more than doubled the rate of treatment for hip fracture. So FLS works. You're going to be hearing a lot about FLS today. And at the end of this, you will be leaving and you will have three options. You have the option of doing nothing, doing a little something, or doing what you need to do, which is FLS. So I'd like to talk about that first one. That's your easy out. And you've got the perfect excuse now. You've got a pandemic on. Well, we are 32 months post-pandemic. So I actually analyzed the data of new FLS implementations in Canada in the 32 months pre-pandemic and the 32 months post-pandemic. And here are the results. There is no slowing down in the rate of new FLS implementation post-pandemic. In fact, if you look pre-pandemic, it was only Alberta where there was a bit of momentum. Post-pandemic, we're now seeing 3 different provinces having FLS. And I would like to showcase a little something, a little highlight. You know, in BC, you're on a roll, okay? You have momentum here. If there was ever time for you to step up, it's now, okay? I would also like to highlight these 3 FLS. These FLSs have all benefited from financial support from the Brookfield Chair. Okay, he's really giving wind in the sails of FLS implementation in Canada. What about this option? Doing a little something. Well, I want to caution you because sometimes doing a little something is not much better than doing nothing at all. Okay. And here are my words of wisdom if you decide to implement a non-FLS. First of all, be realistic. It's not an FLS. It will not have FLS kind results. The overwhelming majority of patients will still be left behind. Now, that second consideration, it doesn't matter if you're implementing a true FLS or a non-FLS, the funding consideration always matters. But you know, the less the model is effective, the less money and healthcare resources you want to dump into that model. Okay, so it becomes even more important to look at costs for non-FLS. I also want you to look at the future. I can tell you that I've been looking at all of this data for a long time. And there are a bunch of, I'm calling them dead-end models. The model is done, it's maxed itself out, it's reached the ceiling. And it, unfortunately, because either the location they put the FLS at or the type of background the coordinator is hired at, or the infrastructure that they've given to that model, it cannot be ramped up to full FLS. And in those jurisdictions, we're now looking and seeing that to start an FLS where there's a non-FLS, they have to start from scratch completely. Okay, they cannot use the existing model. In fact, once they implement an FLS, the existing model will be obsolete, will have to be shut down. So if you're implementing a non-FLS, be careful that it's one that you'll be able to ramp up to full FLS rate. And I cannot overemphasize collect data. It's important. So I very much hope that nobody can leave this room at the end of this meeting without this compelling urge to do what's right. And it will take some effort, it will take some time, and it will take your determination to not draw back and say, oh, okay, I can't do it FLS, I'm gonna have to do a little something, okay? And you'll have to be careful that you don't end up falling in these common traps, because even in 2022, those same traps that we all fell in 15 years ago, people are still falling in those exact same traps this year. So your guide to success, without a doubt, will be the OC essential elements, OC FLS KPIs. So I urge you all to make sure that you make their first break their very last one. So I'll take questions. I didn't even get that yellow card.